morning, and profuse thanks to Dr. G. Vijay Kumar, Dr. Venkatramanan and others in the organizing committee for inviting me today to this 3D con. From in the sea of diabetes, I'll be different. I have to switch gears to a different endocrine dysfunction, second most common endocrinopathy, we can put it that way, after diabetes, and discuss about basic thyroid functions and the interpretation. And being a predominantly diabetes conference, touch upon the interactions between diabetes and thyroid and some practical points from that. A lot of you are physicians, obviously practitioners here. Some of you are much senior to me. You will all remember how in the era before the assays were developed for hormonal estimation, a lot of tissue-based and clinical parameters were used. In fact, our professor used to carry a knee hammer to diagnose hypothyroidism. From that era, we have gone to the level of nanomoles, picomole estimation within a fraction of a second, and today you can get free T4 assays within an hour. So much of the list given here are more of historical value. The thyroid functions can be interpreted not only for screening but also for confirmation of the dysfunction by simple hormonal assay, which includes the two hormones secreted by the thyroid and the feedback pituitary hormone, which is TSH. So I mentioned already, I'll go through some of the case scenarios and stress upon how to interpret these functions. To recapitulate basics, T3 and T4, the number of iodine molecules along with tyrosine, mention the triiodotyrosine and tetraiodotyrosine, which is otherwise thyroxine, secreted by the thyroid gland in the neck. And it has a nice three-tier endocrine feedback, negative feedback system with the pituitary and hypothalamus. This we all know. Couple of points to be mentioned is, this is all in iodine replete state. In iodine deficiency, this whole thing may slightly go topsy-turvy, and you need a normal carrier, which is thyroid binding globulin and albumin also for effective functioning of this system. Two basic. One point which we always probably overlook is this. This slide is the most important slide to interpret thyroid tests. You can see here this negative feedback mechanism has a very unique quantitative relationship, which is called negative logarithmic relationship. Even within the reference range of the lab, if the T4 drops from a higher normal to a lower normal value, you can have the TSH jumping several fold. So it is not just increase, negative feedback, it is logarithmic or exponential increase is what you should remember whenever you interpret thyroid tests. If this is caught well, then most of the cases which I will be running through along with you will not be too difficult to understand. From that, we will switch on to this first case where a typical 24-year-old lady in the era of master health checkup and general check goes to a family doctor. Some vague symptoms, everybody is bothered about even few kgs weight gain. So there was some suspicion by the doctor because of her irregular cycles, tiredness, fatigue, etc. And he orders a thyroid test. Here you can see thyroid, the hormone. By the way, a disclaimer before I go on to the cases is we are not discussing lab errors here. You should be sure about the lab, and we are presuming that all are done in the best of labs and double checked. Okay, don't ask me which lab. Okay, so free T4 is clearly below the limits of the normal and TSH is very high. So this is negative feedback mechanism. So how do we interpret? Clinical symptoms were there. So for any test, please remember there should be a pre-test suspicion. Then only your interpretation will be more confident as a clinician. And this patient had pre-test suspicion, thyroid hormone levels were low, feedback is well maintained, TSH is very high. Diagnosis, very clear, this is called primary hypothyroidism, to mention the fact that primarily the thyroid gland is affected and it's not secondary to a pituitary or a hypothalamic damage. Unlike in other branches of medicine, secondary doesn't mean that secondary to another etiology. It is autoimmune always, and here you have to replace thyroxine, and simple straightforward diagnosis. In contrast, the second case will also be not too difficult for you now to understand how in a patient, 40-year-old mother of two, recent weight loss and palpitation, neck fullness, which is thyromegaly, and typical stare in the eye, very obvious that she has Thyrotoxic features, lab is confirming that high T3 and T4 values. Free means free from albumin, free from globulin. It is the free hormone. TSH is suppressed. Today's assay, the ultra-sensitive 4th generation TSH assays done in the commercial labs standard will be 0.0001. You can go to that level. That means it can detect up to that level. So the TSH cannot be 0.3 here. The TSH has to be like this. Then only the interpretation. So the negative relationship in an exponential manner will hold good even in the lower side where the TSH goes very low. Again, obvious case. Preclinical suspicion of toxicosis was glaring. Hormonal levels were clearly increased. Negative feedback mechanism in the form of appropriate TSH suppression was clearly visible. So this patient is diagnosed with thyrotoxicosis. However, the differential diagnosis will not only be hyperthyroidism where the gland is over-secreting, but it might also rarely include thyroiditis where the gland is undergoing an inflammatory damage and the stored hormone is released into the blood. That will also produce the same picture. And in this situation, we are not discussing the last, which is most common in clinical practice, and that is over replacement of hypothyroidism, which will also produce a similar picture. The time will not permit for me to discuss how will you differentiate. History will tell you whether the patient was on thyroxine, but clinically how to differentiate hyperthyroid and over replacement of thyroxine. The star of Graves, etc. won't be there. That we can, if time permits, discuss. Next situation, this I think will not be too difficult for today because you have understood the logic of interpreting. Here, non-specific symptoms, this girl goes for thyroid functions. So here you can see, in contrast to the previous two situations, thyroxine is normal, nearly on the lowish normal. TSH is elevated even if it is normal. This is what sometimes confuses many of us. Again, lab should be double checked. Here the clinical symptoms were not there. So the suspicion of hypothyroidism was not that much, but the patient undergoes a thyroid function test, which is routinely done today, you all know. And feedback is operating somewhere and TSH is going high. This diagnosis is called subclinical. There is no sanctity in this word subclinical because many times patient will have vague symptoms. Suppose instead of saying that she has no symptoms, I said that she had weight gain, she had some mild irregular cycle. You might call it a symptom or a no symptom, I don't know. However, it is a biochemical diagnosis based on normal T4 and elevated TSH. It is not a clinical diagnosis. That's why it's called subclinical. Purists in endocrinology in some older textbooks may call it euthyroxinemic hyperthyrotropinemia, if you want to call it that way, you can say. Because it is not clinical at all here. It is based on the lab. But you know the mechanism now why it's happening, because this patient might have had a value instead of 1.1, 1.8, and from 1.8 it would have dropped to 1.1 and the TSH is showing some elevation. That means there is something wrong with the thyroid which is in the evolving phase. It's not gone to the clear-cut overt primary hypo, but it is in this stage of subclinical hypo. That's what it means. But the differential, so you can have a spectrum of subclinical thyroid dysfunctions before the patient develops very low T3, T4 and very high TSH. This is what you should remember, that you can have phases of this where initially T3 will be low, then T4, then TSH elevation with normal T4. So this is what we want to pick up some cases. This carries significance in certain clinical situations like pregnancy, infertility, some of the other cardiac situations. Otherwise, more often this need not be treated. The differential diagnosis of this kind of a report where the T4 is normal but the TSH is mildly elevated includes the first one which we all are interested in is the autoimmune hypothyroidism in its evolving phase. I want to pick up that patient who will develop overt hypothyroidism over the next few years so that I can treat her now. That's what is the first one. However, host of other conditions like partially treated ones, recovering from thyroiditis, recovering from recent stress, very common. Recent viral infection, thyroid test done, TSH can be elevated. Lot of other non-thyroidal conditions, adrenal insufficiency, pituitary, hypopituitarism in the evolving phase can also have this, lithium, amiodarone, and the last but not the least is obesity. Obesity per se can cause elevation in TSH. There are a lot of reports on that, how leptin and other things play a role here. Just to tell you that you randomly check 100 patients who are grossly obese with TSH, it is very likely they will be elevated. And this minute homeopathic dose of thyroxine is not going to help them. And weight and thyroid are unfortunately not that closely related. This is what we should try to explain to our patients. Very commonly asked question in our meetings like this is, should thyroid be checked in fasting or not? Because even diurnal variations can vary TSH. We had tried to answer in a couple of our papers where we showed that TSH is definitely more in the mornings, especially if done in fasting was the first paper. But the doubt created in this was whether it was the time or food which caused this. We had to do one more study where we analyzed this more and showed that it was the timing rather than the food which actually caused the TSH. So you do a morning sample of TSH, if it is very likely to be higher than an evening sample. So putting it in another way, if you want to rule out these minor variations in TSH, it is better to do a morning sample of TSH. Evening TSH, even though you may get in 1 hour today, ultra fast TSH assays are available, it is bound to be lower. So in pregnancy, fertility and certain special situations, I will be happy doing a morning sample rather than a random sample at any time of the day. So now I require some of the audience to answer this question. 32-year-old lady, she has headache, weight gain, menstrual irregularity, increased sleepiness, many of which may indicate that there is some thyroid dysfunction. She undergoes thyroid test. T4 is very low. What is happening to the TSH? It is normal. Here only the problem comes. In a typical epidemiological sense, we say that TSH alone is enough to screen for thyroid dysfunction, but you will miss this patient where the T4 is very low, but the TSH is normal. So the pre-test probability is very high here. There is some problem we are suspecting, but the TSH is not giving us the answer, in spite of T4 being low. This is called inappropriately normal TSH. That means TSH should have gone very high, 100, 200 like that. It's only 2.9. That means the problem is with TSH. It is not with T4. This is pituitary dysfunction. TSH is abnormal. It's not the thyroid gland which is abnormal. So you can diagnose a pituitary problem even with a basic thyroid function test, provided we milk the T4 and TSH correctly and interpret it correctly. This patient underwent an MRI directly, and this was confirmed to be a pituitary tumor. You can get the clue. Many times TSH can be low also, in which case suddenly somebody may put her on carbimazole or something. That's even more risky to do. This patient is very important to diagnose this, because you have to give steroid first and then only thyroid. Don't replace with thyroxine first. That is clinically wrong, because it will accelerate the metabolism of cortisol and patient may go into adrenal crisis. This will be the case scenario before, I think. So this is a pregnant lady. Today in pregnancy, thyroid is routinely done. Many of the labs, they do total, which is bound, protein bound T3 and T4, which is very much elevated. From what the last 5 minutes of discussion, you know that you should interpret first TSH. With this elevated T3 and T4, TSH should have been suppressed, which is not happening. What is the point here? Pre-test suspicion, we didn't check. This is a routine check. Thyroid hormone levels, total values are high. TSH is not suppressed. Is there a problem? Here only we should remember that we see the patient first. Don't see the numbers first. She is pregnant. That's the important information we have. So total hormones will be high because of the high thyroid binding globulin. If you check a free hormone, they will be normal. So first see the patient. In the context of the patient only see the blood report. This is because of the HCG and the thyroid binding globulin going high because of estrogen excess in pregnancy. Well-known fact, but many times overlooked. Suddenly the gynecologist may get worried by seeing a very high T3, T4. You need not check even free T3, free T4. 1.5 times total T3, T4 of non-pregnant values are taken as cutoff for pregnancy. So this is the standard graphs available in lot. So you will have a higher free T4 and a lower TSH during the first and second trimester of pregnancy. A mild thyrotoxicosis is the rule in early pregnancy. And it's not only pregnancy, there are other conditions which can alter the thyroid binding globulin, which may include any amount of liver dysfunction by any condition, including our hepatitis due to non-alcoholic fatty liver or any condition. So please interpret the patient first and check them whether they have other clinical parameters which will alter the thyroid. There are a lot of senior physicians who may be involved in sick patients. If at all you have a sick patient like this patient given here as a scenario, ICU, ventilated, multi-organ problems, etc., and weaning problem. They check a thyroid. T3 is on the lower side, lowish, very low. T4 very low, but TSH is again low, which means what? The feedback is not operating. So pituitary dysfunction will be suspected, and MRI will be ordered unnecessarily. The logic is not this. Again, see the patient first, not the thyroid report, because during any sickness, you'll be surprised to know that TSH is suppressed because of all the counter-regulatory response, including cortisol and all the catecholamines. So TSH will be invariably low. It will be a mild hypopituitary kind of appearance, which will recover after the patient recovers from the acute. This is called non-thyroidal illness or sick Q thyroid syndrome. Patient is sick, but thyroid is normal. Thyroid is not sick. That's what it means. Thyroid is getting adapted to the sickness, and that adaptation will be sometimes misinterpreted as a wrong report. So this has to be kept in mind. And don't check thyroid unless you are too sure what you are dealing with in any sick patient, is the message from this case. So a couple of slides on thyroid and diabetes interactions, which will be relevant for today's conference as well as for our practice. In hyperthyroidism, in contrast to what we want to do in diabetes care, there will be elevated GI emptying, beta cell dysfunction secondary to the thyroid hyperthyroxanemia. Hepatic glucose output will be high. A peripheral insulin resistance component is there. So all of this will invariably elevate the glucose. To the extent that the ADA classifies diabetes, you have secondary diabetes, secondary to endocrinopathy, you have hyperthyroidism listed. So that's why you should be always remembering this. The paradox in weight here is, in spite of trying, you don't be very happy when routine diabetic, obese diabetic start losing weight. Sometimes you can have other endocrinopathies or other conditions losing weight. Please remember, this could be interpreted in a wrong way. Other effects of hypothyroidism, as I said before, uncontrolled diabetes itself, especially in DKA and other very severe hyperglycemic conditions, can make the thyroid functions abnormal. Recent reports, though not clinically significant, are giving suggestions that metformin can suppress TSH. A very strong association between type 1 diabetes and autoimmune thyroid disease, because both are background autoimmune conditions. And in the era of extensive glitazone use, you could have had quite a few patients who have had even diabetic retinopathy, the macular edema worsening. Same way you can have thyroid associated orbitopathy, the ophthalmopathy, infiltrative ophthalmopathy worsening with glitazone due to the fat deposition in the retroorbital tissues. So these have to be taken into consideration in a given situation when you are treating these thyroid conditions. So please remember, no type 1 diabetic patient should go without thyroid screening every year. It's a message, clear message. That is a definite association, and you have to treat it appropriately, not only for the overall metabolic improvement. In children with type 1, growth will be affected if you don't treat them appropriately with thyroid. So this couple of scenarios in diabetes and thyroid, you can understand this master health checkup being routinely done, where this patient has diabetes by the current definition, where the 2-hour glucose is more, but the thyroid was routinely checked in this checkup. So if you have thyroid toxicosis along with a minor early evolving diabetes, please, whether you do, it's very likely to be type 2, but you cannot rule out the interference with thyroid toxicosis causing an abnormal GTT. Always treat the thyroid first and repeat a GTT before labeling her hyperdiabetes, and don't prescribe suddenly metformin, which she will be already losing weight now. So give her first an allowance for thyroid, treat it well, and then go for more treatment. This is a clear-cut dyslipidemia in a young 40-year-old lady who has diabetes for 6 years. Reflexly prescribing statins should be sometimes done with caution, because you could have secondary dyslipidemia, secondary to like hypothyroidism, secondary to 40-year-old lady, irregular menses, oral contraceptive pill, secondary to any other drug. So always look into secondary things, because unless you treat the reflexly prescribed statin, it is very clearly known, even though it may not be a guideline, that if you give statins in a hypothyroid patient, it will worsen the myopathy. So myopathy will be more chances if you don't treat the hypothyroid first. So it's very easy to get a thyroid value before treating. So always render them euthyroid before attempting to intensify your diabetes or thyroidism. In addition to all this, because thyroxine will not only have effects on metabolism, it could have effects on bones and heart, there have been attempts to generate thyroid analogues, mimetics they are called, One such one published few years back in NEJM is this eporitrome, which has its effects only on the atherogenic dyslipidemia without the detrimental effects of thyroxine on bone and other muscle conditions. So not in use, but it may be. Just last slide. Metformin and thyroid, there is definitely some suppression, but not of clinical importance, but in a given patient you have to be sometimes careful interpreting the TSH going low. In addition to that, we know that liraglutide and the host of GLP-1 analog in the animal studies have shown to have some C-cell hyperplasia. The rare event of that patient with medullary thyroid carcinoma, please avoid any of them. So in summary, I'd like to close with this last slide saying that interpretation of thyroid function tests and treatment is not just with numbers. Please be careful and please see the patient holistically before coming into any conclusion. Thank you very much for your attention.